Now, in our fifth and final section, we will talk about the glottic carcinoma. And in this, we will talk about the carcinoma in situ and invasive carcinoma, sub and supraglottic cancer, and vocal rehabilitation after total laryngectomy. So after total laryngectomy, as a mean of the treatment management, if the larynx is removed, then we need to perform the vocal rehabilitation. So all that we will discuss in this fifth and final section. Carcinoma in situ. Carcinoma in situ, which is small but non-invasive cells are present. That's the carcinoma in situ. We have subglottic region, we have supraglottic region, and that's the glottis. So that's the thyroid cartilage, thyroid membrane, and epiglottis. So carcinoma in situ. Treated by transoral endoscopic carbon dioxide laser. So through the oral cavity, endoscopic carbon dioxide laser is used for carcinoma in situ. Stripping of vocal cord is performed. Tissue subjected to biopsy, and the biopsy shows the invasive carcinoma. Radiotherapy is given. So once the carcinoma in situ is treated by transoral endoscopic carbon dioxide laser, tissue is removed for biopsy, and if the biopsy shows that the cancer is non-invasive, small but non-invasive cells, then the radiotherapy is given for non-invasive cells. Biopsy confirms only carcinoma in situ. Treatment is given followed by regular follow-up. So this is the bane. If there is carcinoma in situ, which is non-invasive type, radiotherapy is given. But if it's carcinoma in situ, then we should do the regular follow-up. Invasive carcinoma. T1 carcinoma, that is invasive, we should go for the radiotherapy as the treatment. Excision of cord by endoscopic carbon dioxide laser and laryngeal fissure. T1 carcinoma with extension to anterior commissure, we should give the radiotherapy is best choice. Frontolateral partial laryngectomy, regular follow-up total laryngectomy. T1 carcinoma with extension to arytenoid, we should do the same treatment as for the anterior commissure, and the surgery is preferred in the carcinoma which is invaded to arytenoid. So for anterior commissure, radiotherapy, frontolateral partial laryngectomy, follow-up, and if not, then we should go for total laryngectomy. T2 and O carcinoma, which is invasive carcinoma, is the tumor of the glottic region. We should go for vocal cord, anterior commissure, vocal process of arytenoid, extension to supraglottic or subglottic region, no lymph node involvement. So NO T2. T2 is all these sites are involved, but not the lymph nodes are involved in this type. Treatment depends on the mobility of the cord, anterior commissure, or arytenoid involvement. Next, T2 and O carcinomas, again, depending on if the cord is mobile or if it is not mobile. If the cord is mobile, we should give radiotherapy to primary, including radiation to upper neck nodes. If this is failed, then we should go for laryngectomy, conservative first. Always first conservative. If that is not effective, we should go for total. If there is mobility of the cord is affected, then we should go for conservative laryngectomy, again total laryngectomy. So both ways we should go first for the conservative and then total laryngectomy along with the neck dissection. Again, the condition we already mentioned depend on the mobility of the cord and involvement of arytenoid and anterior commissure. Radiotherapy usually give good results. Regular follow-up is required. Partial vertical laryngectomy for voice preservation. Then we have condition. Again, impaired cord mobility, involvement of anterior commissure and arytenoid. Usually the radiotherapy is not preferred. So depending on the extent of the invasion of the cancer, the treatment options are decided. Perichondritis development entail total laryngectomy. So if the lesion or the cancer is invaded to the surrounding cartilaginous region, then we should go for total laryngectomy. Conservative surgery like vertical hemilaryngectomy and frontolateral laryngectomy. Hemi means half in vertical and then frontolateral laryngectomy. Follow-up and then is important. If there is disease recurrence, we should go for total laryngectomy. So it's very important that we should know the extent of the involvement of the or extent of the spread of the lesion or the cancer to decide for the proper management of the cancer. Again, no NO, neck and T2 carcinoma, if the extent of the tumor is T2 and no node involvement, the chances of occult metastasis nodal is less than 25%. No prophylactic neck dissection is done. If radiation is considered, primary upper neck nodes involved, then we should cord mobility is important in determining the outcome of T2 lesion. T2 lesions are associated with impaired mobility, intrinsic laryngeal muscles or paraglottic space invasion, poor response to radiation if there is impaired mobility. Invasion of paraglottic or subglottic space usually linked with undetected invasion of laryngeal cartilage. Poor survival results. So vocal cord mobility is very, very important prognostic factor. If it is mobile, then prognosis is better. If it's immobile, then it's bad. Similarly, if there is invasion of laryngeal cartilages, that is associated with poor prognosis. T3 and T4 glottic cancer, again best treated by total laryngectomy combined with neck dissection if nodes are palpable. More advanced, treated by combined therapy, surgery with post-operative radiotherapy. Only palliative treatment is done in the advanced stages, which are the T3 and T4 cancer, because it already metastasized to the distant side, and then without palliation, the treatment usually, even if laryngectomy with nodal dissection is done, and the cancer is already metastasized to the distant side, so there is no point in doing that. Subglottic cancer T1 to T2 lesions are treated by radiotherapy, T3 and T4 total laryngectomy along with post-operative radiation. Radiation portal should also include superior mediastinum. Supraglottic cancer, again, factors considered for treatment. We have status of the lymph nodes, mobility of the cord, age of the patient, status of the lung function, cartilage invasions, subsite of supraglottis involved, and status of pre-epiglottic space involvement. So again, all these different factors tell us the extent of the spread of supraglottic cancer, and that tells us what type of treatment is recommended. T1 lesions respond well to radiation, excise with carbon dioxide laser. T2 lesions, supraglottic laryngectomy with or without neck dissection. If poor lung function, we should go for radiotherapy. T3 and T4 total laryngectomy with neck dissection. Again, post-operative radiotherapy is done in T3 and T4. Vocal rehabilitation is very important. Esophageal speech, in which the patient is taught to swallow air. We don't have larynx anymore to produce the sound. So patient is taught to swallow the air, eject air from esophagus into pharynx. Speaking 6 to 10 words before re-swallowing air. Voice rough but loud and understandable. So that's one rehabilitation method in which the patient is taught how to do the esophageal speech. And in people who cannot learn the esophageal speech, we should do the artificial larynx is used, and it is people who fail to learn the esophageal speech. Electrolarynx is a transistorized battery-operated portable device that helps in producing the voice. Vibrating disc held against neck soft tissue. Here, this is the picture which shows the electrolarynx, and in this the vibrating disc, this is held against the soft tissues of the neck. A low pitch sound in hypopharynx is produced. Then we have transoral pneumatic device, that's the transoral through the oral cavity pneumatic device. Pneumo is for the air. Pneumatic type transoral device, vibration in rubber diaphragm occur, and this is sound converted into speech by modulators. These are the options in which the person is not able to learn how to do the esophageal speech. Uses expired air from tracheostome. Vibrates the diaphragm, and that helps in producing the sound. So these are few methods in which we can rehabilitate the person so they can be able to express themselves and speak some words, even though that are not like the actual voice or sound, but they still help the person to live a little less miserable life. Then we have tracheoesophageal speech. In this, the air carried from trachea to esophagus, skin-lined fistula, placement of artificial prosthesis. You can see this is the artificial prosthesis that helps in the production of the sound. Air modulated into speech. Disadvantage of this method, since it's tracheoesophageal, the food enters into the trachea and can cause choking. Prosthesis is shunt air from the trachea and inbuilt valves working in one direction. It prevents the problem of aspiration. So food can enter in the tracheoesophageal speech, and then there is prosthesis which shunt the air from trachea, and we should use the inbuilt valves. The valves, function of these valves is prevent the backflow. So when these valves are used, they prevent the aspiration or entry of the food into the trachea. So that concludes our lecture, and we talked in detail about the types of the cancer, their spread, their management, diagnosis, and the treatment options in detail about all the supraglottic, glottic, and subglottic type of laryngeal cancer. Thank you for watching sqadia.com.